welcome to the Peninsula Vet Emergency and Referral Hospital Vet Wrap, our new podcast series where we explore all things veterinary. We share with you veterinary advice, say careers advice. We utilise the whole team, so our emergency and specialist team, to investigate topics and to discuss areas of interest, and sometimes case reports that are of excitement to us and hopefully to you. So I really hope that you enjoy this series.
All right, welcome back, everyone. Thanks for joining us for episode 4. This is another really exciting one, and one that I think is going to be very informative. So we're going to be talking about RFG, or the Respiratory Functional Grading, that we specialise in at Peninsula Vet Referral and Emergency Hospital, or ERH for short. The title that we've decided for this podcast is RFG, What's in it for me? So I'm going to be asking Arthur, who is the Chief Assessor here in Australia, questions on RFG, because I will be very honest, I've got a very basic knowledge of it anyway. And I do certainly have people kind of asking me, well, why would I use it? Yeah. So I wanted to, I guess, come at you with some pressing questions, maybe about some misconceptions that I or other people have around the scheme. Yeah. I guess the first thing to ask really is, what is it? Okay. So it's Cambridge University's research, which was funded by the UK Kennel Club. Well, they were part of it. And the chief investigator was Jane Ladley. Now, I was super lucky because I know Jane, because she did her residency at the Royal College and was 1 year, I think it was one year in front of me. And we had a lot of fun and did, misbehaved as residents do. God, let's leave that there. Yeah, we should. So hence the association and one of the reasons I got involved. What we knew and what Jane sort of, where the process started, is that we didn't have any system of determining the severity of a dog's airway obstruction. And we know that the population, across pugs, French bulldogs and British bulldogs, is sort of really obvious statement, but they're all different. Funny that, they're different breeds. But in amongst the individual breed, they're also very heterogeneous population. They present in many different ways. And all the work that had tried to correlate anatomy to severity had essentially come to nothing. The different papers contradicted each other. So even laryngeal collapse, which we all say is a bad observation, that's not a consistent negative prognostic indicator across the publications. On the whole, it's considered, but not. You can find papers that say, no, there was no difference between those dogs. The length of the palate is not much use to us. Thickness seems to be. Presence of hypoplastic trachea, but in honesty, hypoplastic trachea is a small percentage of dogs. So we had a problem as clinicians in that, how do we know that this dog is really bad? Because, of course, we want to know that before we intervene, because essentially the assumption is if a dog has really severe airway disease, it's got a higher chance of things going wrong. Now, concurrently, we had, Jane started this work some time ago. We had a rising awareness that brachycephalic breeds have numerous welfare concerns, and one of the most important and significant is airway obstruction, BOAS, and that if we were to be able to change these breeds in the future through more appropriate breeding selection, which we've done with hip dysplasia and elbow dysplasia, and I'm not an ophthalmologist, eye disease and heart disease, that area out there, through grading schemes, then why can't we do it with BOAS? So there were two things happening in parallel. We need to develop a scheme that can estimate severity so that the clinician can use that to essentially get an indication of this dog might cause me trouble in hospital. And we needed a scheme that could estimate severity so that we could then advise breeders as to which dogs to use to breed moving forward. So that's where it all came from. Now, It wasn't entirely unique. There were already exercise-based functional tools. So there was the 1K walk. It's how long does a dog take to walk a kilometre?
Okay.
That could take a long time.
Wow.
And then there was a 6 and a 5 minute walks, which was how far they could go over a certain length of time. What Jane recognised by doing some work with human respiratory physiologists is that you need to convert the dogs from closed mouth breathing to open mouth breathing to have a complete assessment, and hence she chose a trot.
Right.
And that's the big difference. But what's also different is that through the research that Jane did, the respiratory functional grading scheme is validated against lab-based measurements. So we can have a degree of confidence that the score that we assign is indicative of their upper airway obstruction.
Okay, so the severity we talk about is how severe the level of obstruction is.
Yeah.
Okay.
So how much compromise do they have to their upper airway?
Okay. And what are the requirements? Like what are the levels involved? Like is it like ABCD? Is it?
Yes. So the scheme is validated in pugs, French bulldogs and British bulldogs. So work at the moment is working on, I think Jane said 14 other breeds.
Oh, wow.
I should pay a bit more attention, but it's a number of other breeds, yeah? And so in the pug, French bulldog and British bulldog, they're assigned grade 0, 1, 2 and 3. 0 is a dog who's considered bias negative, so doesn't have evidence of upper airway obstruction. 1 is they have mild upper airway obstruction that's not of clinical significance, a bit like dogs with hip dysplasia that aren't lame. 2 is a dog with moderate upper airway obstruction that has moderate clinical impact. And 3 is severe, like that dog's in trouble. And 3, they're severe, like they really are. Yeah.
And so how are we then assessing it? So we're doing our 15-minute trot. Is there...
3, not 15.
I'm so sorry.
Yeah.
3-minute trot.
That would be hard work. Yeah. So,
well, you did say you were fit in the other podcast, so I mean, I just
someone
assumed.
else told me. So we essentially need to evaluate the dogs at rest in a calm environment.
Okay.
That can be challenging in the anxious dog, of course. And we're observing their respiratory pattern and their respiratory noises. Now, there's essentially 3 predominant noises: nasal stertor, pharyngeal stertor, and laryngeal stridor. And there's differences. The pugs have a different algorithm. So there's an algorithm as to how you assign the grade, and the pug algorithm is different to the French bulldog and British bulldog, super important, because the pugs have a higher level of stridor because they're predisposed to laryngeal collapse.
Okay.
That's interesting, isn't it? Baby pugs have laryngeal collapse, yet we keep saying it's a progressive component.
Yeah.
Think about that.
Yeah.
Anyways, sidetracked. So we observe them at rest, then we trot them at 6 to 8 kilometres an hour, 4 to 5 miles per hour. And my experience is you really need to run with the dogs because sometimes they are doing characteristics whilst they're running, but some of them recover so quick that by the time you pick them up and put them on the table to examine them at the end of the 3-minute trot, that the respiratory noise you heard during the trot is already resolved. So that's a little bit of a nuance. But essentially before, during and after, then based on an algorithm of the type of noise they have, whether or not they have dyspnea, whether or not they regurgitate, you then assign a grade based on the highest or the most severe observation, not an averaging and not the lowest. It's always the highest. So the dog is essentially a grade 2 on all aspects except for 1, it's a grade 3. It's a grade 3.
Okay.
Yeah.
So then I guess one of the things that I hear is, you know, if 10 people listen to the same dog, they're going to hear or they're going to grade the noises in 10 different ways. Is there a way that we can listen and avoid that? Is that a bit standardised with this or...?
That's a risk of any grading scheme. I mean, if you look at CHED, so canine hip and elbow dysplasia scheme, one of the ways they've tried to prevent that is to nominate who are the official interpreters of the radiographs. Yeah. The problem that we have for the RFG is it's an assessment tool that is done, we can't transport the test to an assessor. So you take an x-ray and then you email it to the assessor. You can't email the assessor the dog. So we have to have more than 3 assessors or whatever it is for Australia. So we have had to have a lot of people involved in order to make the scheme available.
Yeah.
Yeah. So that is a problem. So yes, there will be variation between the individuals. Fortunately, the algorithms, the way they've been created by Jane, is that they essentially they limit the capacity for variation, because when it comes to the different noises, it's super simple. 0 is you can't hear the noise external to the dog or with a stethoscope. 1 is you can only hear it with a stethoscope. 2 is you can hear it outside the dog. And 3 is the dog has dyspnea, like it's distressed, yeah?
That seems pretty kind of...
Yeah, so if you can hear stertor, it has to be a grade 2 or more.
Yeah.
If you can only hear it with a stethoscope, it's a grade 1.
So it's not necessarily then I have to hear certain squeaks or certain snorts with my stethoscope. It's a little bit more broader and wider.
It's not overly subtle. One of the problems is that when Jane was doing the work, she had a final year student doing a final year student project, and they filmed all these different dogs that were assigned different grades, and that was put on YouTube and was available to the world. Those dogs... Unfortunately, those videos have led to people undergrading dogs because it was like go and teach yourself how to do an RFG, but with no understanding of the subtlety. Yeah. And also that series of videos are quite severe. So Jane has redone videos which are not available for public distribution, and the dogs in that are. It's a vastly better series of videos, but their severity of noise is much less than the YouTube dogs. Yeah. Okay. So those YouTube dogs have unfortunately led to people going, "Oh, I can do this. This is super easy," and then they're tending to underestimate considerably.
Yeah. Okay.
But if you can hear a stertor or a stridor, or you have a continuous nasal stertor that you can hear outside the dog, it is a 2 or more.
Okay.
Yeah.
Okay. Yeah.
If you have an intermittent stertor in a bulldog or a French bulldog with sniffing, or you can only hear the noise with a stethoscope, it's a 1. If you can't hear stertorous noise or stridorous noise with a stethoscope, it's a 0.
Okay.
Yeah. Okay. So it's not that difficult.
Yeah, no.
Yeah.
Yeah, okay. And so one of the other, I think, big things that I assumed, and I think a lot of other people assume, is that the grade that I end up assigning to this dog will determine whether that dog needs surgery or not.
Yeah. That's a really unfortunate. And it is in the paperwork that essentially the interpretation of the grade. So 0 says, doesn't have bias. 1 says it has mild upper airway obstruction of no clinical significance. 2, it says seek veterinary attention. 3 is needs intervention.
Okay.
Yeah. So that was along the way. And I guess it sort of makes sense, doesn't it? So Jane creates these grades, and then she needs to add a comment to, well, what do you do about that? Yeah. And then people have taken that, and how many examples do we have of this in veterinary, where people take a publication or a piece of information and then apply it without thought, and that's what's happened. So the grading scheme was never meant to be used to decide if a dog in isolation, to decide if a dog should have surgery or not. It is a tool to help us in the process of evaluating the individual dog. Okay. I wouldn't do a hip replacement on a dog just because it had a radiograph with dysplastic hips.
Yeah,
so
very
I wouldn't
true.
do it. Yes, I got that right. I said
Yeah,
hip
you did.
replacement. Yeah. Sorry, I had that. Did I say dysplasia twice? That would be madness. I'd take the dog out for a walk and see if it's lame, see if it has pain. And in fact, that influences my decision for a hip replacement vastly more than the radiograph. And RFG is the same. It's a tool. So we have to sit down and do a comprehensive consultation process where we're asking about whether the dogs can sleep, whether the dogs can eat, how much they actually exercise. I mean, here's the thing, isn't it, is that the respiratory functional grade was designed to give us an assessment of the degree of upper airway obstruction. It doesn't tell us if the dogs have sleep apnea. It doesn't tell us if the dogs can eat. It doesn't tell us if they have heat intolerance. It doesn't tell us if they can exercise for 30 minutes. It's not trying to. And that's what I quite tiny bit unusual. You hear these comments, people saying, well, it doesn't tell us if the dogs can exercise. And it's like, nope. And a radiograph doesn't tell us if a dog can walk. Like, what sort of nutcase are you? Like,
well, then I guess it comes to the question of, as a GP, why do I need to do it?
Well, to be completely honest, as a GP working with a brachycephalics, you don't have to do it. That's the other thing. No one said you have to do it. But you do have to accurately and comprehensively evaluate these dogs. You can't look at a brachycephalic and say you need surgery, because if you do that, there's 30 to 40% of the dogs you've just done surgery on that actually don't have a clinically significant upper airway obstruction. And this idea that surgery will prevent laryngeal collapse, we have zero evidence that that's true. And we don't even know how laryngeal collapse progresses. We don't even know how many dogs actually get it.
Okay.
Like no one's done, because that's an impossible study. You know, let's get 100 dogs when they're 6 months old, anaesthetise them and looking at their larynx, and then every 6 months anaesthetise them and look at their larynx, and not do surgery on any of them and see how many of them get laryngeal collapse. We can't do it.
No, the ethics would go crazy.
Well, the dogs would go crazy too. So we have these big assumptions, and they're not accurate at all. And that's something that always motivates me. I don't cope when our profession embarrasses itself, when we get these really hard-lined opinions and we all rush off and do something, and I'm just as guilty, don't get me wrong, but we don't have any evidence, yet we're supposed to be scientists. And we do a lot of that when it comes to brachies. Yeah. So why would you use it? Because it's a really easy tool to add to your comprehensive evaluation of the individual, so that you can start treating these dogs as an individual rather than you're a bulldog and you need surgery. And also, we know from work that about 60% of owners have no awareness of the severity of their dog's disease. If you get them to run with you, if they can, which many can't, but if you run that dog past them, because it's really interesting. They go, oh, we're only going to trot for 3 minutes. Like, oh, that'll be easy. And like a minute and a half in, the owner's lying on the ground panting their eyeballs out, and the dog's doing just fine. But they can see their dog struggling. They're like, oh, my dog has a problem. Oh, I never realised. Oh, he's never done that at home. It's like, yeah, but how long do you walk your dog for? Oh, the driveway to the post box and back. Or, oh, he plays in the garden with the other dog. It's like, yeah, but for how long? Oh, 10 minutes, and then he lies down. They don't exercise them, yeah? Or if they've subconsciously realised that they can't cope, so they've modified all the behaviours so the dog never presents with respiratory noise. So you take them out and show them, and they're 100% on board now.
Yeah.
Also, when you say that's a really bad noise, because this whole thing, don't normalise what's so abnormal.
Yeah.
They go, oh, wow. Oh, yeah, well, when he plays with the neighbour's dog, he's like that. It's like, yeah, he's trying to die. Yeah, please stop doing that.
That air hunger,
Yeah, that's right.
Yeah.
So it's a great educational opportunity for you as a vet to the owner to get them to engage in the process. Because obviously the next conversation after you've said, look, I think we should do surgery is, and your dog could die when I do this.
So I guess then that's a good place to use it, like you said, as part of your toolkit. So if I grade a dog and they're a 0, and I have an owner that's maybe a bit panicking, saying we need to do all of these types of surgery because I saw it on Facebook, you can say, look, clinically, his physical exam is this, his, owner questionnaire, he seems fine at home. He's also a grade 0. I don't think that doing surgery on him, looking at the bigger picture, is going to be beneficial. Whereas if you've got the owner with a grade 3 or 4, who's
2 or 3.
2 or 3. I'm so sorry. 2 or 3, who is saying, oh, they're doing really well, I'm just here for my vaccine. You can say, let's just do a quick RFG. And then you can say, okay, I think we actually need to look at a bigger picture here and maybe plan out our lives a little bit more and, do some adjustments, be it surgery, be it environmental, be it exercise, diet, whatever. Yeah. Okay.
And it's so important to acknowledge the limitations as well. It's like, I have a conversation with them and say, this won't tell us whether or not your dog can cope with heat, and surgery is not going to resolve that either. It's part of the education. Your dog will be heat intolerant by virtue of its breed.
Yeah.
So you need to be really careful with that, and surgery's not going to solve that problem for you.
Yeah. So it's like the screwdriver in your toolkit. It won't build your house completely, but it'll help you.
Add a hammer and you're halfway there. Yeah. So the other thing though that you are probably going to ask me next is the saying your dog doesn't need surgery, hey, Arthur, that's pretty brave, isn't it? Yeah.
Controversial.
Well, it is, isn't it? Because if that dog goes on and develops airway disease later, Arthur said my dog didn't need surgery. But I don't say that.
Okay. What do you say?
I say today your dog, based on your history, which would include an accurate assessment of its sleep patterns, it's the way it eats, and I ask really specifically, how do you exercise your dog? Oh, on the lead. For how long? Exactly how long? Oh, this long. And then I show them a video of a dog with stertor. Does your dog do this after the exercise? Oh, yes. How long does that last for? And I ask them for a number. Oh, 40 minutes. It's like, that's bad. Yeah. And they've just told me the dog runs around and it's absolutely fine.
Yeah.
So ultimately dogs coming to me, a very large number end up with surgery because we're asking the right questions and we're finding out what they're like, and we're using RFG to help us assist in that process. But if they are a dog who really doesn't have a clinically significant upper airway obstruction, it's not a case of your dog doesn't need surgery and goodbye. Education. Your dog could have progression of this disease. We don't know if surgery will stop that progression. If you're super worried about progression of disease, most vets would say to you, surgery will help reduce the progression. We can do surgery if you want. I'm not so sure if that's the right thing to do, but yes, I acknowledge that is sort of the accepted norm to some extent, not that there's anything to support that. But what we can do is reassess your dog annually, or if anything changes. And by this stage, they've heard all the different noises. I have that many videos on my phone, and I think I say 5 times a day, I really must organise these videos as I scroll through 300 images.
Just make an album.
Yeah. Well, I've made a noses album, but it's like 300 bloody videos in there, and I can never find the one that I want. Yeah.
Okay.
Yeah.
So then we can repeat the grading then for those
absolutely.
lower grading dogs.
Absolutely.
Yeah. Okay.
And it's sort of easy if a dog's 7 and Jane's works, she hasn't published, we should get on and do that, suggests that progression of bias occurs up to 3 to 5 years of age, and then it tapers off and you don't have progression unless you get obesely fat or something changes in your life. So, and that's also super important too. Like, because we have a tendency to be breedists or breedism, good word, then we tend to assume they have upper airway obstruction. Doing an RFG can actually reinforce to you as the clinician, this dog does actually have upper airway obstruction. So I've had dogs come to me and it's like, this dog needs airway surgery. I've even had medicine specialists telling me that. I've gone, this dog doesn't. The classic one was a dog with a reverse PDA. I ran around and said, this dog has a reverse PDA. And everyone looked at me and was like, nearly swore then. You're talking rubbish, Arthur. Yeah. I'm like, no, it does. And I was basically bullied into doing airway surgery on a dog with a reverse PDA. Of course, it didn't get better. And then it was like, Richard came out and guess what? Had a reverse PDA. Yeah. And how did I know? Because I ran that dog. It didn't have airway noise. It was collapsing and it essentially had differential cyanosis. I was like, I'm sure it's got a reverse PDA. Felt like a bit of a hero. Hey, I can diagnose just by looking at your dog's eyes.
The crystal ball.
Oh, yeah.
So I guess...
It's also called pattern spotting, but anyway.
we want a bit to that.
No.
So then I guess what's the overarching goal of this? Is it so that eventually, just like the hip scoring and things like that, in 10, 20 years' time, we're only breeding those 0 and 1s?
Well, exciting. So released this week, email from UK Kennel Club, they've changed the breeding recommendation. So the recommendation was don't use grade 3s. And there was criticism about that because like, hey guys, but 2s have moderate disease. What on earth are you doing? But don't forget that in elbow dysplasia, you can breed a 1 and a 1 has elbow dysplasia. Because there's a flaw in the system. There's always a flaw in the system. So they've changed the recommendation now. They're saying they call it amber. So grade 2 dogs are considered amber. Grade 3 dogs are red, like do not do.
Yeah.
But it used to be that use a grade 2 to a 0 or a 1, but not to another 2. Now they're saying don't use grade 2s.
Okay.
So that's already changed, but they're a little bit in front of us. But that we follow the recommendation of the UK Kennel Club. So we've seen an improvement. So the goal is absolutely don't use dogs with clinically significant disease. Equally, and we have to acknowledge, do we know this is going to work? No.
Yeah.
But it took nearly 30 years for the data to come out from hip scores to see that it actually had worked, and elbow scoring systems. So we couldn't possibly have that information yet.
Yes, yeah.
But hey, what's the harm in what we've achieved, in that we have achieved increasing awareness of this problem amongst breeders who are engaging in the process?
Yeah.
It's remarkable.
And that's a huge thing, to engage the breeders and to have them change is huge.
It's actually, it's one of the most rewarding things I've done in a long time. Breeders coming up to me and saying, if I had known what I knew now, I would not have bred this dog.
Wow.
How about that for a great statement?
That's huge.
It's massive.
That's huge.
And the Victorian Bulldog, British, French and Pug groups have made it mandatory to do RFG if you want to have, what do you call your breed certificate again?
Oh, yeah. Well, I think it's quite good though, because, for the GPs, if I'm grading and I have a breeder that comes to me, I'm able to grade their sires and dams and say we need to, be crossing this one with this one and this one with that one. And just like you're saying, it's really, really good.
Yeah.
So then how do I go about getting trained to do my grading?
Well, you're a little bit slow on the uptake of already trained. Like
I have
80,
been
90 people.
asking.
Yeah. Well, unfortunately, it's a one-person show called me, and my full-time job
is podcasting.
is that. So I have been flying around Australia training vets, and it's very sporadic. So whenever I can get it done. Okay. Fortunately, I have amazing people around me who put it out on Facebook and say, hey, there's an RFG training day. So we get good uptake. The breeders are approaching vets that they know and asking them to get involved. The next training session actually is in Hobart.
Ooh.
Which I had said yes to and forgotten and got reminded about last week.
I'm not shocked.
Yeah. On the 19th. I'd quite like to do another one here in Bulla, because we do it at the Dogs Victoria showgrounds in Bulla, which is 10 minutes from the airport. So to be honest,
super
you
handy.
can fly. Yeah, and I start at 11 and finish at 3, so you can fly in from interstate.
Oh, amazing.
Do the training and fly home same day. Yeah.
Super easy.
Yeah. And so it's easy. And this is how engaged the breeders are. They bring 30 dogs as demonstration dogs. So we do just do a little lecture, talk about the noises, talk about how the system works, bring out all the dogs. They all run around. Some of them are very severe and a bit hard to watch because, in fact, we've got less of those dogs because they're all having surgery now, because I'm sort of like, because their awareness has changed.
We need to do something.
Yeah, we sort of can't keep just running this dog around, So we'll have to find some of the more severe ones for people to see. But that's what we do. Yeah.
So I guess anyone who wants to know of possible upcoming training can just flick a little email. Yeah. So education@penvetreferral.com.au.
Yeah, exactly. And even if I need people who want to do RFG days for the breeding community, because there's two parts to it. There's doing it for the breeding community, and you need to be wanting to educate. And you need to also be able to be very neutral with your opinions. Like, I'm here to do an RFG. This is your score. This is what it means. I'm here to educate you, because part of the RFG process too is to try and educate what are the risk factors. So stenotic nares is a risk factor. It doesn't say you have airway obstruction, but it's repeatedly recognised through various publications that as a risk factor. Wide skulls, so in the pug, the width between the eyes, and in the French Bulldog and Bulldog, the width of the skull, and thick, short necks. Okay. So we have a bunch of PDF images that Cambridge have produced, which you can download, and we're scoring these dogs and say, if you want to produce puppies that don't have upper airway obstruction, we would recommend you choose 0s and 1s, but also look at their nostrils. You want a dog with open nostrils. You want a dog with a narrow but longer skull. You want a dog with a longer and thinner neck. Interestingly, longer noses hasn't correlated with decreased risk of airway obstruction. So that advice is probably not so valid. Yeah.
Which isn't surprising when you think about the anatomy anyway.
Yeah, exactly. And also, why do griffins not have upper airway obstruction?
I love a griffin.
Yeah, and that's actually something else that's happening here in Australia, which is slightly a little bit, I put myself out there for this. So we are grading the brackies that are not pugs, French bulldogs and British bulldogs. So we've graded a lot of griffins, quite a lot of Bostons now. A lot of the boxer people are really keen, and they're turning up in large numbers. Actually, Rotties, believe it or not, because they're starting to go down towards a more brachycephalic skull, and they're starting to get involved, and chows are starting to get involved. So we're seeing the dogs that don't yet have a validated algorithm, but we're essentially going, if you're equivalent to a 0 and 1, we'll call you negative. If you're equivalent to a 2 and 3, we'll call you positive. But that's how keen these engaged breeders are.
Which is amazing, because it just goes to show that, the biggest issue with these guys, and I really, whenever vets tell me, God, I hate brachycephalics, I always say, you don't hate them, you're scared of them.
Yeah, exactly.
And you are really upset at watching any suffering.
Yeah.
And so doing something like this, we're only ever going to be improving suffering, which is just the goal, really.
Yeah.
I don't think that the goal should be to get rid of them necessarily. I think the goal should be to stop suffering of animals. That's, the main thing.
I think we're all aligned with, however you do and contribute to that process, we all believe the same thing. It's a welfare issue. We need to do something about it. We just don't all agree on how we should do it. Yeah. But I have huge concerns with ban the breed. I mean, banning things has never worked in history, so why is it going to work this time?
Yeah, and I think what it does instead is it ends up alienating owners and breeders, and then we're less likely to be able to stop suffering when people are alienated. Exactly. So that's why, for me, I kind of don't like that discussion either, that kind of line of talking. I think it's not realistic, it's not going to work. Let's just focus on what it is.
Yeah, absolutely.
Well, that was so good. Cool. I want to do some training now. I'm ready. I'm ready to get grading.
All right. But it does mean running. I did 40 dogs a while ago. That's 120 minutes of jogging.
I'm pretty good on a treadmill, as long as I have like a good podcast going. I'll play one of the early ones of ours, and then maybe I'll be able to.
You're supposed to be listening to the dog. Anyway, nice little plug for us. Yeah. And that's a vet wrap. Join us fortnightly for these podcasts. You can access them through our YouTube channel, Vet Education Hub on the Peninsula Vet Care Emergency and Referral Hospital website, and all other platforms that you can source your podcasts.